The endotracheal tube was once considered the optimal method of managing the airway during cardiac arrest. However, intubation attempts by unskilled providers or providers who use it infrequently can produce serious complications, such as trauma to the oropharynx, incorrect placement in the esophagus or right main bronchus, and prolonged interruptions in compressions and ventilations. During CPR, providers should minimize how often and how long they interrupt chest compressions. Healthcare providers must carefully orchestrate intubation attempts to limit the interruption of compressions only long enough to visualize the vocal cords and insert the tube. Despite these hazards, there are many benefits to endotracheal intubation. These include keeping the airway patent, allowing suctioning of the airway, speeding the delivery of high concentrations of oxygen, providing an alternative route for some drugs when intravenous or intraosseous routes are not available, and when using a cuff, potentially protecting the airway from aspiration. The endotracheal tube is a single clear lumen with a single cuff. There are several sizes of endotracheal tubes. Providers typically use a tube with an 8 mm internal diameter for adult males. Adult females typically require a tube with a 7 mm internal diameter. Before attempting placement, verify that the cuff will hold air. And check that the laryngoscope is working. It will click when locked into place. There are two styles of laryngoscope blades, curved and straight. The choice is a matter of personal preference. A suctioning device should be immediately available to clear secretions or other material from the airway. To insert the endotracheal tube, apply a water-soluble lubricant to the tube and insert a semi-rigid stylet. The tip of the stylet should not extend beyond the distal end of the tube. Place the patient's head in the sniffing or neutral position. Place the curved blade into the vallecula at the base of the tongue. Using your left hand, lift the laryngoscope vertically up and away to lift the epiglottis and expose the vocal cords. With your right hand, insert the endotracheal tube directly between the vocal cords and into the trachea until the cuff passes the cords. Markings on the outside of the tube help guide it to the correct level. Once the endotracheal tube is in place, inflate the cuff and attach a waveform capnography monitor to confirm proper tube placement. As you deliver ventilation with the bag, watch for chest expansion and listen over the epigastric area. You should hear no gurgling over the stomach, and you should detect bilateral breath sounds. The absence of breath sounds and the presence of gurgling sounds in the stomach indicate you have intubated the esophagus. Stop ventilation immediately and remove the endotracheal tube.